Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
So what I thought I should talk about today is expand on the acquiring evidence part of evidence-based practice. So we talked about acquiring evidence last time, and I thought I should run through an example of something I would look for evidence as part of my practice and use that to highlight what you can do in your own sort of practice or as you interact with patients. So acquiring evidence is the second step in the practice of ABM. As you already know, the 5 steps are listed on the screen here. Ask, acquire, appraise or interpret, apply, and evaluate or assess. Yeah, so you could think of it as the 5 A's: ask, acquire, appraise, apply, and assess. So we're talking about acquiring the evidence. Last time we talked about types of clinical questions. If you remember, I mentioned foreground questions and background questions. I'll mention them again. We talked about some search techniques like concept building. We talked about keywords, mesh headings, Boolean operators, and searching in phrases within quotes, searching with parentheses or brackets, nesting, and field tags. So I'm going to start off with a clinical scenario, and I'll just highlight or explain how I tried to formulate some questions and then went to search literature and try and find answers for my own sort of understanding and hopefully also for the patient's benefit. So there's a lady in her 60s who was incidentally detected to have raised CA19-9 during workup of her GI symptoms. Now, it wasn't very clear why the CA19-9 was done in the first place, and that is an important sort of lesson for us as practicing clinicians. You don't want to do tests which are not directly relevant to the patient's problems. If not, you run the risk of incidentally picking up abnormalities which may not have clinical relevance, but which may lead to unnecessary testing and intervention. So anyway, she had raised CA19-9, and she's known to have IPMN, which is intraductal papillary mucinous neoplasm of the pancreas. It's a condition in the pancreas that is often picked up on imaging. It is pre-malignant. For certain types of IPMN, resection is considered necessary, important. For certain other types, they're simply observed. So that's something to keep in the back of your mind. It will be relevant later on as I discuss the case. And then she's also known to have a mesenteric cyst. Both of these conditions were being managed conservatively. There wasn't an obvious cause for the raised CEA, and the patient was a little bit worried that she had this tumor marker that was high, and people couldn't explain the reason for the tumor marker being high. And one of the clinicians looking after her did a PET scan, which is partly to address the issue of the raised CA19-9 to see if there's anything else and the underlying problem. And the PET scan picked up a thyroid nodule, and that's how she came to see me. So we dealt with the thyroid nodule, but that's not the topic of discussion here. But I had a few queries about this patient. So I've just listed a few examples, but you could have your own clinical questions. You could have many other questions arising from an encounter such as this. So I was thinking, right, I really need to refresh my knowledge about CA19-9 and refresh my knowledge about what conditions are linked with a raised CA19-9. And then I was thinking, as the patient is worried, I was wondering what is the likelihood of a false positive high CA19-9? or the likelihood of having a high CA19-9 without cancer. Now, if it's a benign condition and the CA19-9 is raised, and that's okay. For most of these benign lesions, such as mesenteric cysts, we wouldn't intervene unless there was a complication. And I then was wondering about what's the likelihood of having a raised CA19-9 in an otherwise sort of benign-looking IPMN and a mesenteric cyst. And if that likelihood was high, then I'm reassured that I can reassure the patient. And the final question I had in the clinic was, now that we know the CA19-9 is raised and we haven't found anything significant, or at least not yet, is there any value in carrying on measuring it to see whether it's going to go higher and higher, or do we just not measure it at all? So these are just some questions that we were thinking about in the clinic. Now, the first thing you might want to do, if as a medical student or a junior surgical trainee, is to gain some background knowledge about CA19-9. So you could do that. Traditionally, we used to do that when I was a medical student by going through the textbooks, hard copies in the library. These days, you can look up online textbooks. And there are numerous online textbooks that some of them are free, some of them you have to pay, that you can access. Another source which can be quite useful is what is referred to as point-of-care information summaries. So, or evidence-based reviews, they're called. And you may have come across some of these information summaries if you subscribe to UpToDate. And there's another one called Dynamed. There's the BMJ Best Evidence. And there are quite a few of these days, which will provide you fairly up-to-date summaries of information about a specific disease, about a specific drug, about a syndrome, or an operation even, and then they can be quite useful. And these kinds of summaries are usually peer-reviewed, so which is good. And some of them are freely available, but a lot of them need a subscription, so they may not be easy to access. Another source, in addition to point-of-care information summaries, would be review articles. And this is what I would go to if I had a question, for example, about CA19-9. I'll come to that in a minute. And I'd go and find a recent review in a good quality journal. Now, you may ask, what is a good quality journal? And trying to identify good quality journals comes partly by reading around a fair bit and doing this repeatedly and gaining experience and knowing how to identify good quality journals and so on. So you search for an appropriate review article, and we discussed before how we search for specific articles on specific topics, how we use concepts and we put the concepts together and so on. And the more you do this, the more regularly you go and search databases to look for good review articles, the better you get at in finding a good article and then obviously reading it. Some review articles, unfortunately, might be behind a paywall, and you might have to, ask your librarian to get it. Very rarely do we really pay for articles. We try and find ways of getting around the payment, usually by asking our librarian, or we simply look for articles that are free to access. Right, so coming back to our question, this lady had a raised CA19-9, and we were wanting to know more about this. So I typed in CA19-9 and review in PubMed, and I stumbled upon this article. And this was in the World Journal of Gastrointestinal Surgery, and it talked about CA19-9 as a tumor marker in a very broad way. And it seemed a reasonably good read. So one of the first things you could do, and I do tend to do this, is to look at the journal, look at the institution, and this is really very important when you're looking at primary research, where the paper is about patient-level data. It's not that important for reviews, systematic reviews and meta-analysis, So the actual institution of the journal may not be that important as long as the review is of decent quality, but that's something to think about. Now, I read this paper. I got lots of useful information about CA 19.9 that enhanced my background knowledge, made me more confident in talking about CA 19.9. I'm not going to talk about that now. And it also gave me some more leads for doing further searches in relation to helping this particular patient. And it helped me refine my foreground question. So having read about CA 19.9 in this review, I found a few important bits of information. So CA 19.9 is raised in several benign and malignant diseases. I didn't know that before, I must say, but I didn't know that CA 19.9 was associated with malignancy in IPMN. So that was a new thing for me. And I did not know that CA 19.9 has been associated with medullary thyroid cancer, I've got to say. Now, then, like I said before, the more you read, the more you'll be able to get further leads for further searches and also refine your foreground question. So then I started worrying about whether CA 19.9 is a good predictor of malignancy in IPMN. And given that this lady is known to have IPMN, which is intraductal papillary mucinous neoplasm of the pancreas, it's like a cystic lesion in the pancreas. And because the CA 19.9 is raised, have I got to worry about that? The other thing, obviously, is does this patient have medullary thyroid cancer? So those are two further foreground questions that I thought I should be looking into. So I'm just going to concentrate on the first question for the next two slides. So if you have a foreground question like the one I mentioned, the best thing to do would be to look up published articles, and you could look them up and search for them in one of several bibliographic databases. So here are a few examples: PubMed, Embase, CINAHL, and I've got to say I just stick with one database, and I stick with PubMed, and I'd encourage you to just get used to one database. You rarely ever have to look at multiple databases to find answers for specific clinical questions. You'd only do that if you're going to do a systematic review. Then you might do 2 or 3 databases to ensure that you've captured all relevant articles aimed to answer a specific research question. So when you search these databases, the most important thing to keep in mind is to start off with a clear, very clear foreground question, because a clear question helps you to come up with some concepts. And you can use these concepts in what we call concept building to formulate your search strategy. Okay, so our question was, is CA 19.9 a good predictor of malignancy in IPMN? So I typed in CA 19.9 as a keyword, IPMN is another keyword, combined them with and I got 90 results on PubMed. This is a very recent search. Keep in mind that the concepts CA 19.9 and IPMN might have alternative keywords. So CA 19.9 might be referred to as carbohydrate antigen 19.9 or Sala-Lewis antigen A, and so on. Similarly, IPMN might go by many different words. So you've got to keep those in mind and maybe use those alternative keywords, or use what we refer to as control vocabulary or mesh headings. And this is something we touched upon last time. So we've talked about that before. 90 results was too much for me. We're busy people. We've got lots of things to do. So I thought if I needed 1 or 2 articles, I'd really love to read a systematic review, which is at the top of the evidence hierarchy. It'll probably include all relevant literature on the topic. So I filtered the search by clicking on systematic review. And lo and behold, I landed on a fairly good systematic review looking at a number of predictors of malignancy in IPMN, right? And this lady has IPMN and her CA 19.9 is raised. So I looked at this review, and the review had 2 really important conclusions. One was raised serum CA 19.9 was the most specific feature that predicted malignancy in IPMNs, and raised CA19-9 yielded sensitivity of 0.38 and specificity of 0.90 in the diagnosis of malignancy in IPMN. So this is important for me because this lady had a high CA19-9 and an IPMN, right? So it's really relevant for this lady. So and that's a very important observation. Now, if you have a test that has got not so high sensitivity, but a very high specificity, and you've got a positive test, that's quite significant. But we shouldn't jump to conclusions. We should just think a little bit about what this means and also consider what the population or setting was in which the various articles in the systematic review were conducted. We should think about what does raised mean? What's the threshold here? And then is that the threshold that you have in your laboratory assay? Are we talking about similar assays? Are we talking about serum and not cyst fluid and things like that? And is there a huge dose response effect? In other words, is there going to be a big difference between what might be considered marginal elevation or something that is 5-fold or 10-fold the upper limit of the normal range? So there are all these things to think about, yeah? And also, if I'm looking at a predictive marker, a biomarker, or a diagnostic test, I'd like to really see predictive values as opposed to sensitivity and specificity. Predictive values are clinically much more important. Now, I don't want to go into the details of this particular sort of concept that we've covered before, and it's kind of out of scope here. But there are a number of things to think about before we jump to conclusions and ring alarm bells. However, a very high specificity or a very high sensitivity can be quite important. For example, if you have a really high specificity, they might help to rule in disease if you have a positive test. So there's a mnemonic called SPIN you might have heard of. SP stands for specificity, P stands for positive test, and IN stands for ruling in disease. So if you have a high specificity and the test is positive, then the diagnosis is virtually confirmed. And here it might mean malignancy in IPMN. Similarly, you may have heard of this mnemonic called SNOUT, SNNOUT, sensitivity, high sensitivity, negative test, you can rule out the disease. Okay, so these are just little things to keep in the back of your mind if you come across tests with high specificity or high sensitivity. But like I said, remember, ideally, you would like to have predictive values, positive and negative predictive values. And those are the ones that are really useful clinically. So how does this help me and my patient? What do I need to do? Now, you've got to keep in mind that you may not be. I certainly am not a pancreatic surgeon. And I've just come across this patient in my practice, in my clinic. So this is enough for me to ask for help. Call the experts, the hepatobiliary experts, or send them to the liver and the pancreas MDT, mention this finding, and make sure that this is reviewed. Make sure that this is taken into consideration along with all the other radiological features and clinical features, and they can make their minds up as to whether this IPMN can continue to be monitored and managed conservatively, or whether they need to think about resecting this. Okay. Now, I've not talked about the other finding in my searches, which is that raised CA19-9 can be a marker for medullary thyroid cancer as well. But again, that's a lead that I'd need to follow. And this is how a quick and easy literature search can help you address not just your curiosity about specific clinical conditions or biomarkers, but also help the patient, because at the end of the day, that's the primary aim, isn't it? Okay, so just to summarize what I've said, be inquisitive. Things might not necessarily be in your direct field of interest, but if it matters to the patient, then we've got to probe things a bit further to see if we have dotted the I's and crossed the T's, if you like, in the management of the patient as a whole. In searching databases and getting to the articles you need, initially you might be quite frustrated, might take you a long time, but with practice, you will find that you get to the information you need, yeah? And you'll be able to zone in on information that is relevant to you and your patient much quicker and much more efficiently. Now, I hope with this example, I've highlighted that there might be lots of protocols on how to manage RACE, CA 199, or how to manage IPMN. There might be guidelines or textbooks. And I call this tertiary sources of evidence, yeah? But they don't necessarily help address many of our day-to-day problems. We've got to be efficient, and we've got to practice looking at primary and secondary sources. By primary sources, I mean original research or patient-level data. By secondary sources, I mean systematic reviews and meta-analysis. Like the paper we just discussed, that's a secondary source of evidence. What you read in a textbook or guideline or maybe something like UpToDate, I would call that tertiary sources of evidence. So tertiary sources of evidence to me help you in your background needs, to build up your background knowledge. But primary and secondary sources often are invaluable in answering the foreground questions that you might have. Okay, that's about it. Thank you very much.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.